Hi, my name is Katie Rogers, and I'm a physical therapist with the Medical University of South Carolina in Charleston, South Carolina. I'm presenting on behalf of myself and my co-authors Rachel Gray, Ethan Bean, and Kara Eid, who also work at the Medical University of South Carolina. Our paper is entitled The Safety and Feasibility of Mobility on Left Atrial Veno-Arterial Extracorporeal Membrane Oxygenation, also known as LAVA-ECMO, and it is a case report. So the purpose of our case report is to show that despite the growing evidence that mobility of patients on transitional MCS, such as ECMO, is very critical in reducing deconditioning, promoting recovery, and improving candidacy for advanced therapies like heart transplantation or LVAD implantation, there are still very real and perceived barriers to mobility of these patients. Specifically with patients with more rare configurations of ECMO, such as left atrial veno-arterial cannulation, it is much less common to mobilize these patients. So we had a patient who was admitted with cardiogenic shock and was cannulated for ECMO via the LAVA-ECMO configuration. And we worked together with our medical and multidisciplinary team in order to mobilize this patient through a safe step-by-step program. We agreed on mobility guidelines in advance and created safety net protocols throughout. We started with only a tilt table and an upper extremity ergometer to assess patient tolerance to mobility, and we slowly progressed in a stepwise fashion from there, including sitting edge of bed, transfer training, and then later ambulation in the hallway. The result was that our patient had a significant improvement in AMPAC score from 11 to a 17, indicating improved functional mobility. And there were also no adverse events during mobilization, which were defined as any hemodynamic instability that could not be addressed with medication titration, no bleeding, and no cannula dislodgement. So in conclusion, we recognize that balancing safety and mobility in these critical care populations remains very difficult. But we were able to demonstrate that with a rare configuration of ECMO, we were able to safely mobilize when we worked together with a multidisciplinary team and followed guidelines and protocols in literature. So this example encourages a case-by-case model to assess appropriateness for mobility rather than just a blanket exclusion of certain patients based on their cannula configuration alone. We hope that this will allow each patient to receive their highest level of mobility within a team-approved parameter. We hope that you've enjoyed our paper, and we thank you for the opportunity to present.